Good morning. Welcome, everybody. We will wait just a minute or so just before beginning today. But while people are still joining the meeting, feel free to introduce yourself in the chat, provide your name or in your current role, position, organization, and state or territory you are joining from today.
Thank you all for being here. We're going to start in just a minute, give some time to more folks to join. We see people are still joining. Welcome.
All right. Hello, everyone. Thank you so much for joining today. We are excited to begin our next episode of our Successful Public Health Approaches in Dementia Caregiving, featuring Utah. My name is Maya Kofsky, and I provide support to the Bold Public Health Center of Excellence on Dementia Caregiving, as well as the Center for Healthy Aging and Innovation at the University of Minnesota School of Public Health. And I'm super excited to have the honor today to kick off this meeting and I'm looking forward to a great discussion. We want to take time today to acknowledge the land and virtual space we are sharing today. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn, honor the traditional Dakota values, courage, wisdom, respect, and generosity. All right, now, just to provide a brief overview of the Bold Public Health Center of Excellence on Dementia Caregiving, or PICO-DC, as we like to call it, for those who might not be familiar. The center is designed to support state, tribal, and local public health agencies nationwide in developing their dementia caregiving focused programs and initiatives by improving access to evidence-based programs and best practices, facilitating connections and collaboration among public health agencies and a wide range of service organizations, as well as providing technical assistance for identifying, selecting, and implementing effective public health interventions and strategies. Feel free to scan that QR code to visit our website, or it will also be in the chat as well. And we also just wanted to briefly highlight the Healthy Brain Initiative, or HBI Collaborative. It's a group that includes population experts, national coordinators, and subject matter experts with the goal to reduce the risk and impact of Alzheimer's disease and related dementias through integration of cognitive health into public health practice. You can learn more by visiting hbicollaborative.org or by scanning the QR code there on the screen. So we very much value your feedback. We do ask you to please take a moment to complete the survey today before you leave the event. You can scan this QR code on the screen or click the link in the chat as well. All right, so let's just quickly review some reminders for the presentation. Please submit all of your questions for the speakers in the Q&A. Please raise your hand if you wish to speak, but only unmute if you are prompted during the Q&A portion at the end of the presentation. Please use the chat to share comments, resources, links, and ideas, and feel free to use your reaction buttons as well. This is being recorded, and the slides, the recording, and the resources will be shared after the event via email as well. And as another reminder, please complete the survey at the end of the event as well. And just a kind of a brief overview of the Roundtable series. This is a bi-monthly Roundtable series for public health. And we would like to highlight the story of one state in every episode that we do. This is an opportunity for networking, peer learning, and idea generation. We hope that this has kind of become a community of practice where agencies can share their successes and learnings and get ideas for action. And now we have a poll question just to kind of see who is in the audience today. Please complete the poll on your screen. And then we'll kind of review some answers as well. All right. As we can see here, we have a pretty diverse audience in terms of which organizations and people are here today. Looks like quite a few public health agencies, community organizations, or service providers, clinical and care professionals, caregivers. Awesome. So good to see everyone here today. So now I would like to introduce you guys to our presenters today. Um, Christy Russell is the Alzheimer's disease and related dementia state plan specialist for the Utah Department of Health and Human Services. In this role, Christy coordinates the ADRD state plan and coordinating council to ensure that the goals and objectives within the plan are met to reduce duplication of efforts throughout Utah. Christy provides statewide education and assists individuals to access resources available to those with dementia and their caregivers, loved ones, and professionals. Christy also manages and maintains the public awareness campaign for ADRD and has served as the public relations chair for the Utah Society for Public Health Education. And Kate Naderow-Steck is a gerontologist and a certified dementia practitioner with 20 years of experience within the long-term care industry, dementia care, and family caregiver support. At the State of Utah's Division of Aging and Adult Services, Kate serves as the program manager for the Caregiver Support Program, overseeing the support offered to family caregivers by the area agencies on aging throughout the state. She also serves as the program manager for Alzheimer's disease and related dementias program, which seeks to improve support to those affected by dementia and enhance dementia services across Utah. All right, and now I will turn it over to Christy and Kate. Thank you.
Thank you so much. We're really excited to be here. I'm Christy Russell. I'll get you guys started and then I'll hand it off to Kate a little bit later. So next slide, please. And we're just going to kind of start off with some demographics and statistics to explain what Utah looks like. Many of you may have never been to Utah. Hopefully you know where we are in the map. After this, you will know a lot more. So next slide. Okay, so Utah is one of the fastest growing states in America. We have a population growth of about 40% in the last 2 decades. We are home to over 3 million people, and we have 29 counties covering 84,000 square miles. So looking at the map here, 3/4 of our population lives in 5 contiguous counties, which is in the yellow. 12 of our counties are considered rural, which means that there's 6 to 100 people per square mile, and that's in blue. And 12 counties are considered frontier. And I said that once in a presentation, and everybody was like, we didn't know states still had frontier. We do. Frontier counties, which means 6 or fewer people per square mile, and that's in orange. So as you can see, that's a huge part of us. The frontier and rural communities receive a lot less federal funding for supportive services due to their lower population density. These areas also have fewer local resources to them. About 40% of our folks in rural and frontier Utah do not have access to broadband internet. Some don't have running water. Some of our tribal populations are still living in like little huts with no electricity or running water. Many Utahns in these rural and frontier communities either don't own computers, don't want to own computers, or they just they like the bill pay in person and doing that. So due to all of these differences in our areas, what works for one county doesn't necessarily work for another. And so really our focus today is to explain how we choose to implement our programs and why implementing programs in all of our counties the same just doesn't work. We can't use an across the board approach. Just to give you guys an idea, San Juan, which is in the bottom right corner of our state, if you drive from one end to the county to the other, it's like a 3 or 4 hour drive. So it's quite a space. So next slide, please. Okay, so Utah has one of the smallest shares of older adults in the nation. Only about 11.7% of Utahns are 65 or older currently. Of these older adults, 1 in 10 only 1 in 10 identify as a race or ethnicity other than non-Hispanic white. So we are a very white state. 1 in 5 of our older adults live alone. We do have one of the highest age-adjusted Alzheimer's disease death rates in the United States. And while Alzheimer's disease remains the 7th leading cause of death in the United States, it is the 4th cause of death in Utah. And so I just wanted to make sure you guys were aware of that. Next slide, please. This is kind of a snapshot of our Alzheimer's and dementia history throughout our state. So in 2011, our Alzheimer's disease and related dementias task force was formed. This task force was comprised of state aging experts from the area agencies on aging, State Department on Aging, healthcare, private organizations, and educational institutions. They were able to get the first Alzheimer's disease and related dementia state plan unanimously adopted by the legislature in 2012. However, it just kind of sat on a shelf at that point. In 2015, the Alzheimer's Association, along with the Alzheimer's Disease and Related Dementias Task Force, I'm just going to say ADRD from now on, they reapproached the legislature to get the ADRD state plan assigned to a department that could implement that plan. So they were able to get it assigned to recognize ADRD as a public health crisis and to assign the state plan to the Department of Health. Also in 2015, with that assignment, the legislature assigned some funding, and we were able to hire one full-time state plan specialist, which is my title now, within the Department of Health, and this also provided additional funds to support the state plan. At this point, 2 coordinating councils were created, one in northern Utah and one in southern Utah. And the state plan specialists work with these 2 councils to implement the goals of the plan. And at this time, funding was limited. It was not guaranteed to be ongoing. In 2018, the second state plan was published, as the first one ended in 2017. And in 2019, contracts with an advertising agency created our first public awareness campaign for dementia in Utah, which was very exciting. And at this time, it focused on the annual wellness visit, which is provided by Medicare. And it urged patients to ask for their brain health check rather than a cognitive screening, as the word cognitive can be some kind of confusing for folks. At this time, additional funds were granted for a second employee named the Alzheimer's Disease and Related Dementias Resource Specialist. And that person was hired, and that person was me in 2019. In 2021, our governor and legislature passed a bill for the Department of Health and the Department of Human Services to merge. We'll go a little bit more into this in the next slide, actually. But the purpose was to improve delivery of services, reduce duplication, and enhance collaboration. In 2022, the Utah legislature allocated funds to Utah State University for our Alzheimer's Disease and Dementia Research Center. These funds were used utilizing our ADRD state plan and its successes, the partners, researchers. We were all really involved in getting this funding, and we were thrilled when it was given. And then in 2023, we published our 3rd edition of the state plan. Excuse me. And I forgot to mention that in 2019, the funding for the ADRD state plan was made ongoing as well. Next slide. Okay, so this is a very confusing org chart, but this is the best one that I could find. So originally there was the Department of Health and the Department of Human Services, and then a little bit of the Department of Workforce Services is involved in this. And there was a lot of duplication. So you can see where the dementia program was housed originally, that circled kind of in that blue teal color. That's where the dementia program was originally. And then, sorry, I got a hair in my mouth. And then we were then moved over to Aging and Adult Services, which I'll explain in a minute, but that's the purple circle. So the benefits of the merge was to reduce that duplication, like I mentioned earlier. So for example, there was a Medicaid program in Department of Health a Medicaid program in Department of Human Services, and a Medicaid program in Workforce Services. So as a community member, you're like, what resources am I looking for? You don't know where to go. It was very confusing. And these three programs would be competing for funding opportunities and things like that. So in 2021, the governor and the legislature passed the bill for the merge to improve that delivery of services. The dementia program was moved from what was called the Department of Health Bureau of Health Promotion to what is now the Department of Human Services, Aging and Adult Services, and we were housed under the Older Americans Act group. The purpose for us being moved under the Older Americans Act was there was that huge reorganization happening anyways. Our coordinating council and partners actually requested to have it moved under Aging and Adult Services, and the legislature is very supportive of our council, and so they heard that. The area agencies on aging that Kate will kind of go into a little bit later, they were requesting more dementia support and resources. And Kate, who, as mentioned, is my supervisor now, she has 20 years of knowledge and understanding of dementia. And I was her intern at the Alzheimer's Association in her previous job. And so we knew we already had a great working relationship and that we could be really successful. And so with all of this, it was decided by the legislature and the powers that be within the Department of Health and Human Services to move me. So that's kind of that explanation. Okay, next slide, please. We thought that it was important to kind of show you how our funding works. We are not funded by the BOLD initiative, and we rely really heavily on our coordinating council and area agencies on aging for our successes. We do not have any national funding at this time, so we are solely legislatively funded, and that means different things for different states. So for transparency, we get about $430,000 per year, and that funding is used to cover my salary, any like admin services, background stuff that we all have in our jobs. It also covers 2 care consultation contracts, which Kate will talk about care consultations a little bit later. We have our public awareness campaign, which is about $45,000 of that funds. And then we have our data collection with the behavioral risk factor surveillance system and other data collection efforts. And then for the most part, the rest of that funding goes out to our area agencies on aging for their dementia efforts. Again, Kate will go into how that works a little bit later. As I mentioned in 2018, in 2015, the first staff was hired, and then a second staff was hired in 2019. With COVID and the merge and everything happening, the original state plan specialist decided it was time for herself to retire. And so as I moved over under Aging and Adult Services, Kate and I made the decision to not rehire for that second position and utilize that funds to go out to the AAAs, which is why we've gone from a team of 2 that are specifically for dementia to I'm the only person that's specifically for dementia. However, I do have the support of Kate in everything that we do, and we're a great team. So next slide. Let's see. Oh, we're going to talk about our coordinating council next. We actually go to the next slide. So here's a question for you all. If you have a dementia coalition or a council in your state, is it an appointed thing or is it volunteer? If you would like to kind of share how your state works, please put that in the chat. We would love to hear from you. I know each state is different. Utah is volunteer, but many are legislatively appointed or appointed by the Department of Health or however it works. Okay, and I'm just going to kind of move on, but Kate can interrupt me if she wants to mention anything out loud. This is a view of our current state plan. If you're looking, oh, excuse me, thank you for moving the slides. If you're looking for some beautiful pictures of Utah, I'm really proud of what we've put in here, but also a lot of information about our state and our process. With the changes following my predecessor's retirement, we really focused on switching it from a state-run plan, meaning that it's operated by what was the Department of Health and now Department of Health and Human Services, and reporting based only on the Department of Health successes and what we were doing. So, for example, instead of taking into account all of the education done across the state, we were only looking at what we had done internally. So our numbers were pretty low because there was only 2 of us. We have now made this a truly state plan, which means we report out on our efforts statewide as one collective unit. And this has encouraged more partners to share their data with the council on courses offered, attendee information, location, etc. We're really, really excited about that. We are able to gather some data, and we're getting numbers from partners who have never shared this before because they want to be a part of these numbers, and eventually and hopefully recognition and maybe some funding and things like that from the legislature in the future. Our partners truly believe in our cause and hopes that this moves us forward in quicker, which is exciting. We'll talk more about our data collection towards the end, though. The council assisted not only in writing the plan, but provided many hours of reviewing and editing. And this has been quite the work in progress. And we wouldn't have been able to do it without our fantastic council members. And I saw a couple of your names pop on here. So you know who you are, and thank you. Next slide, please.
So Christy, before you get into the next slide, we did have a couple folks jump in here about their coalition. It seems most are a voluntary coalition, which is interesting. One is a kind of a mix. They have got legislatively appointed, but then a group of volunteers as well. So that's interesting to see. So we appreciate you all sharing that.
Thank you so much, Kate. Mm-hmm. All right, and when I look over, it's because I have faces over here on the screen to my right, and I'm looking at you guys in my camera straight forward. So my apologies there. Okay, so this is our council's vision and mission for our state plan. I won't read it to you all, but I think it's really important to understand that we took input from our entire council and kind of created this, and it's been our mission. Really, it's been changed very little from our original plan back in 2011, 2012. So it's something we're really holding on to. Next slide, please. Okay, so these are our 5 priorities, which are basically goals, but we refer to them as priorities in our current state plan. While each of these priorities are separated in our plan, there's really a lot of overlap and collaboration amongst the work groups that focus on each priority. So we have our overarching council, then we have separate work groups that focus on each priority. And each of these work groups actually has 2 chairs who lead the groups. While I attend each meeting, my voice is heard. I have a lot of input. I've really chosen to play more of a supportive role, which I think is important to keeping this a fully statewide plan. So first we have our dementia aware work group. And really the focus, I'm going to go through some of the things we work on. The focus is on reduction of stigma of dementia and raising public awareness of risk reduction, that dementia is not a normal part of aging, the Medicare annual wellness visit, and any resources and supports throughout the state. Then we have our dementia competent workforce, which focuses on education and support for all employers statewide. That's a huge undertaking, and so we're working on it. And we want to improve education and resources for healthcare professionals and encourage businesses to become more dementia conscious and supportive. I mentioned we have our research center, so we actually have a expand research goal or priority, excuse me, and that priority is led by one of the people who run the Dementia Research Center, which is a fantastic partnership. And the goal there is to promote participation in research studies, encourage statewide collaborative research. The Alzheimer's Disease and Dementia Research Center actually provides mini grants to Utah researchers for their work in dementia and caregiving, which is very exciting. And then we have our Living Well with Dementia group, and they focus on increasing the availability and utilization of resources for those living with dementia, reduction of stigma, promoting advocacy, and empowering those with dementia to live a full life with confidence and dignity. and enhance and expand services and activities statewide. Then last but not least is our support and empower caregivers work group, which our next speaker, Kate, is one of the chairs for that. And it is to improve self-identification of caregivers, which we all know can be a challenge, increase visibility, availability, and utilization of services and resources, prepare, educate, and support caregivers throughout their caregiving journey, empower caregivers to become advocates for the health and well-being of themselves and their care recipient, and improve financial and workplace security available to caregivers throughout our state. So that just gives you kind of a snapshot. I know that they posted the link to our state plan in the chat as well, so feel free to go ahead and take a glance. Next slide, please. As I mentioned, our coordinating council is completely voluntary. Right now, this is kind of a snapshot of the makeup of our council. We have caregivers, folks from higher education, state government. We do have Department of Health and Human Services programs, but I am pleased to say that that is that bottom left. It says DHHS staff in like the peach color. We are not the biggest piece of that pie anymore, which is very exciting. We have long-term care businesses, hospital systems, home health, and nonprofits who participate. This chart was originally created to show the diversity in our council, and we had all kind of assumed that the Department of Health and Human Services was going to be the biggest piece, and it's not, and we're really happy with that. At least annually, we do reevaluate who is represented on our council, who is active, and who is missing. We typically find that underserved populations and other chronic disease experts are needed. We do our best to reach out to these groups and invite them to join via networking, or we participate in their councils or attend their conferences, things like that. We also meet with potential partners to introduce them to the plan, the work we do, and kind of just have that one-on-one relationship. We currently have over 180 people who are part of our council, receiving the meeting invites, notes, newsletters, and other materials that I send out via email. About 60 of those attend our regular quarterly meetings for our council. That being said, a lot of the folks who are unable to attend the meetings, I do hear back from them via email telling me they want to stay on our list, so we keep them. By allowing the council and its work groups to remain completely voluntary, participants can work on projects that they're really passionate about. So rather than splitting up the council and saying, hey, you're part of this work group, we actually let people choose where they would like to be. And I think that has really helped our engagement remain as high as it is. Next slide, please. So I mentioned, if you remember back to the snapshot of our history, that we had two coordinating councils. When COVID started in 2020, as we all know, everything went virtual. And so we actually decided to merge these two councils into one, since all meetings were held virtually. We are continuing this. People are really getting a lot out of working with each other. Our folks in our rural and frontier areas are learning from our rural or our urban folks, and vice versa. And I think that's been really beneficial. The council exists to increase collaboration, reduce duplication as funding is limited statewide, and create materials that can be co-branded. So really anything that our council creates is shared amongst our partners and can be utilized on their own social media, radio, advertisement, however they want to use it. At each of our council meetings, I provide updates. We also have a Healthy Brain Initiative moment where I cover, myself or one of our partners covers a Healthy Brain Initiative piece and educates on that. We have an educational speaker, which rotates based on request and interest. And then we provide time for partner updates at the end. So each council partner has the opportunity to speak up if they would like to share what's going on in their organization. The work group chairs and myself work very diligently to ensure that all voices are heard within the groups and that input is received. Some of us don't love speaking out in meetings verbally. So we also send out meeting notes and we ask for email comments or provide a survey to allow those who didn't want to speak out loud to still provide their input. Sometimes this can get a little bit messy, because a lot of comments means a lot to go through, but I think it's really important for our success. In February, we also launched our new Coordinating Council website, which is dementia.utah.gov. This is still a work in progress. We're still taking in feedback from partners and community members. And the work groups were essential to the creation of this website, and it will continue to be a living document. Things that are visited regularly will stay. Things that never get clicked on will go away, and we'll replace it with something more helpful. Next slide, please. Oh, go one up. The coordinating count one down. I think we're missing a slide. Okay, well, you can't see it, but we have, with the launch of our new website, we did create a rubric for partners listed on our website. This provides an equitable opportunity and incentive for organizations to be active. And this rubric includes participating in quarterly meetings, going to work group meetings and participating, providing education or support groups, distribution and promotion of any of our materials, and then representing our council by doing speaking engagements or anything like that. I will make sure that they have a copy of this slide, and maybe we can add a picture of it later. But the rubric provides an example. So it does talk about what they can participate in. So you have attending quarterly meetings, engaging with a work group serving as a work group chair, education support groups. And then one of the things I want to mention about the education is there's a lot of options that they can choose from, but they can also reach out and say, hey, my community really wants this dementia education. Can it count towards our being listed on your website? And Kate will go over all of the different education options. So I'm now going to pass the time over to Kate to discuss the area agencies on aging, or the AAAs for short. Sometimes when I say AAAs, they think of the auto company, so don't think of that. So Kate, it's all you.
Thanks, Christy. Hi, everyone. It's a pleasure to be here with you today. I appreciate the opportunity. As Christy mentioned, we partner with the area agencies on aging, or the AAAs, here in Utah. We do that in order to expand the reach of the Alzheimer's disease and related dementia, or ADRD program. As Christy mentioned, we are a small program with minimal funding, as she explained. And like in other states, there's so much need. So really partnering with these organizations has been beneficial for us and allowed us to reach further into the state. So next slide, please. Before we talk about how the ADRD program works with the AAAs in Utah, we have a question for you. So if you wouldn't mind putting in the chat, are you currently partnering with the area agencies on aging in your state? Why or why not? We would love to learn more about that. We're curious as to what this looks like outside of Utah. As we'll go into, Utah is a very partner-oriented state, and it just kind of makes sense for us, and it's a natural tendency for us to partner with community organizations. So partnering with the AAAs has been seamless as well, and a kind of a no-brainer. So we're just curious as to what works in your state. And if you'd like to provide a little more detail in the chat as to what that partnership looks like, please feel free to add that as well.
This is a great question. Thanks, Kate. And it's mainly for public health departments, right, that are on the call to kind of speak to that partnership, right? Because we have a variety of people in the audience.
Sure, absolutely. I know when I was with the Alzheimer's Association, I partnered, of course, with the area agencies on aging as well. So obviously partnerships with the AAAs can look very different. But yeah, as far as the public health perspective, that's really what we're interested in now. So yes, thanks for the clarification. While those answers are coming in, and thanks for that, I'll go ahead and continue if we can move on to the next slide. So if you aren't familiar already with what area agencies on aging do or how they came about, I just wanted to provide a brief history. So the Older Americans Act was enacted in 1965 with the goal of supporting older Americans to live at home and in the community with dignity and independence for as long as possible. The AAAs, or the Area Agencies on Aging, were born out of the Older Americans Act. In fact, they were added to the act in the 70s, in the early 70s, to be the boots on the ground organizations charged with helping our country's vulnerable older adults. The Older Americans Act mandates that the AAAs use the flexibility provided in the law to ensure that local needs and preferences are taken into consideration, and that resulting local service delivery system is really tailored to the community. So remember back to what Christy said about Utah's landscape, and what works for one county doesn't work for another. The AAAs are really adept at meeting the unique needs of their community and tailoring service delivery systems accordingly. In Utah, we have 12 AAAs who blanket the entire state with support and services for older adults. On this slide, you're seeing a map on the left that's showing the county breakdown for each AAA. The map on the right you've already seen. Christy shared that, but we'll take a look at that one first. So as a reminder, the yellow area in that map on the right indicates our urban counties, blue is our rural counties, and orange are frontier counties. So then you can compare then to the map on the left so you can see how it all kind of lays out. You'll notice on the map on the left, some of our AAAs cover only one county, and that's due to a high population of that county. Most, however, support multiple counties, which can mean significant travel for them to reach members of the communities that they're serving. We'll head to the next slide, please.
And Kate, while they're switching sides, it looks like we have a lot of AAA folks on the call, which is super exciting. And
Great.
I'm hearing a lot of that they work with the AAAs because of the collaboration. They know their communities and things like that.
Perfect. That's exactly what we're seeing in Utah as well. I love that folks are aware of the AAAs and partnering with them. I've said for a bit, they're the best kept secret in every state, which is unfortunate. They shouldn't be a secret. So I'm glad that the word is out there. As far as Utah, why did we decide to partner with the AAAs? As I mentioned, the Area Agencies on Aging make up a nationwide aging network that each blankets their community service area with supportive resources. And as we're seeing in the chat and in agreement, the AAAs really are in tune with their communities. They know how to meet the needs of their service area. They're flexible, adaptable, creative, and really invested in their communities because they're from that community. They're not outsiders. They understand the culture of their area. They understand the challenges of their area. They understand the benefits of their area. Now, as Christy mentioned, each area of Utah has unique needs. So in rural Utah, it can be really difficult to bring education or support groups. Caregivers in this area may not want others in their small town to know the challenges that they're facing. We hear often from case managers that they see their clients routinely at the grocery store or other places, and everyone knows everyone else. So in fact, some of the smaller towns in Utah prefer to, if they have internet, they'll prefer to join virtual education, or they'll participate in telephone support groups that AAAs from other counties offer so that they can attend without embarrassment or judgment. So really in Utah, collaboration is key. That's a big message for us today. The AAAs work very well together as a whole as well. So one example, Salt Lake County is our Area Agency on Aging for that county. They cover the most populated county in the state. So they have the most funding. They receive, and because they have the most funding, they have the most staff, right? So they're able to really build programs where other AAAs don't have the bandwidth, but they share with the entire state so that we can all benefit. The same with translating materials into different languages. When one AAA does so, the entire state benefits. And the smaller AAAs also have ways that they can support the larger ones as well. They bring of course, different perspectives and creativity that the AAAs who have lots of resources don't have, as they really, really honed these skills over time. Finally, one program in particular that the area agencies on aging implement is the National Family Caregiver Support Program, which I'm going to go into here on our next slide, please. So let me take a step. Thanks. So the National Family Caregiver Support Program, this was established and added to the Older Americans Act that I mentioned before in 2000, and it focuses on family and informal caregivers. So while the Aging Network has always been involved in meeting the needs of care recipients and caregivers by creating the National Family Caregiver Support Program, Congress explicitly recognized the important role that family caregivers occupy in our nation's long-term services and support system. So really highlighting the important work that family caregivers do. Now, while the program is called National Family Caregiver Support Program, we know that family caregivers come in all forms. They may or may not be blood related, and they could mean family of choice. So keep that in mind as we mention family caregivers going forward. It's really a broad term to incorporate anyone who's an unpaid supporter of another person. Now, my role, as has been described, is to oversee the Alzheimer's disease and related dementia program, where, of course, I work very closely with Christy. But I also oversee the way Utah implements the National Family Caregiver Support Program. I sit at the state level and work with the various caregiver support teams that each AAA has. You can see here on this slide the services that's provided through this program. And so to get connected to the caregiver support program, individuals can either reach out to their specific AAA, as each will do promotion within their service area. Sometimes folks get referred to me and I will find out their needs and get them connected to their local AAA. Or we have also a form on both our Department of Health and Human Services website, as well as the dementia.utah.gov site that Christy mentioned, where folks can fill out that form, reaching out, asking for help. So just to explain a little bit about these services, each AAA provides information about the resources that they offer, as well as what else is available in their community. They're well aware of who else is providing services in that space and have partnerships with those organizations in their service area. Referrals will occur back and forth on a routine basis in order to make sure that needs are being met. The AAAs also will help with connecting individuals to all of the resources that they need to really provide that well-rounded support. As far as counseling services, I like to refer to this as care consultations. These are also offered through the National Family Caregiver Support Program. We know, of course, that caregiving is overwhelming, and it's helpful to have a guide through this process. And that's really what a care consultation is. It's helpful for caregivers to be able to sit down with a professional and discuss topics like their needs or major pain points in caregiving, how to keep their care receiver safe at home, managing their own stress as a caregiver, navigating the confusing forms and paperwork and eligibility for services that's out there, respite services and other options, or even medical equipment or supplies that could be helpful to that caregiver. Caregivers don't know what they don't know. And so having a professional to be able to kind of open that door to what's available around them and help to get them connected can make a huge difference. So this is really, we find care consultations are really a great way to individualize support for each caregiver and help that caregiver step off on the right foot. Also through the program, support groups are provided. This is really a great way for caregivers to connect with others in a similar situation. It provides, that support there. And as well as allowing caregivers the opportunity to learn tips and tricks as they go. Education programs provide training on specific conditions like dementia, or They can help caregivers learn how to plan for the future, maybe end-of-life care, those kinds of things. Next, you'll see respite is listed. So that really offers the opportunity for family caregivers to take a break on an occasion so that they have the ability to continue providing support for as long as they're needed. And then finally, what's offered through the National Family Caregiver Support Program is what we call supplemental services. And these are services that help caregivers along their journey. And so that might be resources like an emergency response system or incontinence supplies or durable medical equipment that can really help that caregiver and make their life a little bit easier. We'll head over to the next slide. And you see here the list of caregivers that the National Family Caregiver Support Program focuses on. So first and foremost, adults who are either providing support to individuals over the age of 60 or to individuals of any age with Alzheimer's disease or a related dementia, or could be older adults who themselves are caregivers. So they're providing support either to children or to adults with disabilities. So you can see here, there's a commonality between Utah's ADRD program and the National Family Caregiver Support Program, where both is focusing on caregivers of individuals with dementia. So it really makes sense as to why we would collaborate together on this. We'll head to the next slide. So initially, when the ADRD program began in Utah, we focused on the implementation of and promotion, I would say, of 3 dementia education programs. We just kind of honed in on these 3: dementia dialogues, dealing with dementia, and dementia friends. And we only really provided funding and support to organizations who were offering these specific programs. When Christy and I began working together, we realized we were missing out on a lot of other programs that could be helpful across the state. Again, knowing each area is different, we've reiterated that. The initial 3 dementia education programs weren't going to work for each area. So we began to support expanded program offerings, such as the education list that you see here. This is just the list of education programs, but we're now including any dementia-focused activity as one that the ADRD program will support. So not all of these programs, of course, are used statewide. Again, it depends on the needs of each community. When we do have a program that we think the AAAs will like, or other programs will, other organizations will like, we reach out and assess interest. And so if there happens to be statewide interest, then the ADRD program will cover whatever costs we can at the state level. So for example, we're in the process now of covering all training and supply costs for the AAAs to be able to implement Dementia Live across the state, because the interest is there and the need is there. So another example of kind of how we work together. One thing we're also supportive of is allowing each AAA to really tailor their programs. So we've already mentioned that we let each AAA decide what they want to offer. They can pick and choose their programs that work in their area. But sometimes the way they want to offer the program can be individualized as well. So, for example, one AAA might take a traditional education course that's typically offered in a classroom format and decide to provide it on a one-on-one basis in a person's home. Or another might add to the course, extending that program. So we give the AAAs the ability and the flexibility to meet the needs of their community, how they see fit. Again, they are the experts in their service area. So we really lean into that. Next slide, please. So we wanted to take a second to talk about how the ADRD funds are used, and wanting to pass along as much funding as possible. And again, allow for personalization of services. Sometimes we've gotten a little creative in how we supply funds. And we can do this because, as a reminder, our ADRD funds are provided by our state legislature. So we have a lot of flexibility there in how we use them. So in addition to the list that you see here, the traditional use, I would say, of funds such as offsetting staff time for holding a dementia support group or an education program, or using funds to, cover printing costs for education manuals. We've also had some AAAs be a little creative. One, for example, has used funds to cover exercise equipment. So a little background, this AAA has a brain health center within their building where clients can come exercise, and one of their 2 treadmills broke, which didn't allow for individuals to walk together side by side. We were able to tie the purchase of another treadmill to dementia risk reduction due to the exercise factor as well as the socialization factor. And we have a main couple who uses that treadmill who's actually a caregiver and their loved one with dementia. So that ended up working out in their favor. Another example is an area agency on aging who hosts dances every other week in the evening. These are hugely popular in that area and actually very intergenerational, as not only older adults will attend, but high school students as well as kids and grandkids all come out. It's really an entire community event. And so being able for that AAA to be able to use ADRD funds to support these dances allows them to continue. And of course, we were able to again tie that into dementia risk reduction, as well as a fun social activity that caregivers can now do with their care recipient with dementia. So it ends up being tied in that way. We've even used Alzheimer's disease and related dementia funds for respite supplies. So, for example, kits, caregiver kits that caregivers can check out from either their local library or their AAA. Each kit has activities inside that caregivers and their care receivers can either do together, or there are some activities that the care receivers can do on their own, allowing their caregivers to step aside and kind of take a break for a minute. Next slide, please. We wanted to take some time to get into the data collection that we have around our program. So as Christy mentioned, initially the state plan was seen as solely the Department of Health plan and was not a statewide plan. As a state who relies solely at this point on our annual legislative funding, we cannot afford to ostracize anyone. We have to collaborate to extend our reach. There's so much need that we cannot let funding stop us. So we started engaging tons of community partners. And if you remember back from the coordinating council pie chart that Christy shared, that includes caregivers, long-term care, hospital systems, healthcare providers, academia, so on and so forth. And as I shared on a previous slide, we went from focusing on 3 dementia education programs to being able to expand program offerings to include any dementia-focused activity. We initiated surveys for when any organization, not just AAAs, provide support groups and education programs. So they were able to, after each event, fill out a survey to let us know how that went, how many people attended, things like that. After a bit, we realized having organizations complete these on a quarterly basis would be easier for them. So we're beginning that reporting schedule this month, actually. We will also be adding surveys for community engagement programs and programs for persons living with dementia soon. And so that just will bring in the other aspects of our focus within the ADRD program. So now we're collecting data statewide from all partner efforts, and we're not limiting ourselves to specific programs. Our main data source at this time is the BRFIS, or the Behavioral Risk Factor Surveillance System through the CDC. The ADRD program sponsors both the caregiver and the cognitive decline modules that we implement every other year for a full calendar year. So this is really a good snapshot as to what is happening across the state. And we happily share this data with community partners so that we can be a good community partner as well. We also have something called the Chronic Disease Reporting Rule, and this is a pilot study that just ended. So we recently just got got access to the first round of data, so we're excited to start digging into it to see what it tells us. But ICD-10 codes, CPT billing codes, and national drug codes are automatically reported in a de-identified and a de-duplicated way to the Department of Health and Human Services via electronic health records. And we're hoping that this data will allow us to target our efforts across the state for caregivers, for individuals living with dementia, and providers who may need additional education or support. We also have a good relationship with the Utah Indian Health Advisory Board based out of the Department of Health and Human Services. Each of the tribes in Utah is represented within that board. And as state employees, we're required to work with this board if we want to engage the tribes. We can't just reach out outside of this group, but this really is a great opportunity for us to connect with the movers and shakers in each tribe. We've discussed doing programs with the board, and there is an interest in both caregiver and dementia education within their communities. A few years ago, we were further along with offering educational opportunities in collaboration with the tribes. And then COVID happened. So as you all know, COVID's been something. And it really has affected these communities, and the tribes have not been able to prioritize dementia caregiver education until very recently. As far as data, we have been asked that when we do begin these programs, that we not collect data outside of the number of people who attend the trainings. Also in Utah, we started to utilize a statewide calendar of events. This is offered by the Utah Commission on Aging, another amazing partner of ours, and it's free to partners of the Coordinating Council as well as all the AAAs. Partners can add any events they offer, such as support groups, education programs, conferences, and more to this calendar. And individuals who want to attend can sign up via the calendar. We're going to go ahead and put the link to the calendar in the chat, so you've got that. So feel free to open that up and take a look at that. You'll be able to see when you do that individuals are able to really search for the programs or events based on whether or not they're in person or virtual, maybe the area that they live in, or the type of program that they're looking for, such as a caregiver support offering, if that's what they're looking for. So it's a great way for folks across the state to really look and see what's available in their area. Christy receives a quarterly report on any dementia programs that have been uploaded into the calendar, and then she can also run reports on her own if needed. We absolutely understand the necessity of data, but as you're all aware, data collection can be difficult. So we've talked about kind of the change that's been going on in Utah, and prior to the ADRD state plan becoming fully statewide, data collection on our efforts was much, much simpler. So we find ourselves now working on overcoming the challenges of collecting statewide data. So we'll head over to the next slide. And, so yes, so to summarize, what works in Utah to reach more dementia caregivers really is partnering with our area agencies on aging. We've already discussed several benefits of this partnership, but I want to highlight just a few here. So first, this partnership, it allows us to extend our reach across the state. We're able to get into other communities that Christy or I, just working independently, would not be able to reach. By leaning into the expertise of the AAAs, we can tailor programs to meet the needs of their communities. So again, not just a broad approach, but really providing that those tailored offerings in each community. Adding Alzheimer's disease and related dementia funds to the National Family Caregiver Support Program funds that each AAA receives really just allows us to do more. And we feel by utilizing a large statewide voluntary coalition that people are invested in what we're doing and they contribute. Utah's ADRD state plan and resources can be found on our website here that you'll see. Dementia, of course, it's dementia.utah.gov. Remember, as Christy mentioned, we just launched mid-February, so we're still building this website out. But we'd love for you to review what we have so far and provide feedback. We'd love to hear from you. Next slide, please. So we wanted to pause and see if we can answer any questions before we share our contact information with everyone.
And I do want to add, and I know it was in the chat and not in the Q&A, but someone asked about data that we're collecting on caregivers and the efficacy of reducing burnout. And we do have a survey that goes out through the caregiver support program with the AAAs, which is anonymous, and it's actually hard copy mailed directly to Kate. And we do collect that data. And so I kind of pulled up those numbers. Kate, I'm assuming you don't know them off the top of your head. Maybe you do.
I do have them. If you, it's up to you.
So as a result of our caregiver support program, 85% of our folks were able to provide care for a longer period of time than they would have seen possible without the services. 76% have delayed placing their loved one in some sort of long-term care, and 88% felt more self-reliant, which I think shows success in the program. I'm not saying that's due to the dementia funds, even though I wish it was, but our case managers and our AAAs are just fantastic, and I think that calls out to how great they are.
Yep, I agree.
Thank you. Thank you so much, Christy, for pulling the question out. I was keeping track of it. And thank you, Kate, for the wonderful presentation. Earlier, you mentioned like Utah is not a BOLD funding program. I put in a link so folks can learn about the BOLD program, the national program, but really there are so many lessons that can be taken by BOLD funded public health departments from your work and how creative Utah has been in using limited funding really to create this amazing partnership between public health and the aging service provider network, and creative ways you use your ADRD funding to supplement the Older American Act funding. And the treadmill example was, I really thought is very illustrative of that. We have some questions, and just as a reminder, please put your questions in the Q&A. We have 20 minutes, 25 minutes left to answer them, and we would like to have this as a conversation time with our speakers. I will begin with one. I'm particularly curious about your care consultation program that you mentioned today. Could you tell us a little bit more about the program itself? What roles administer it? Where are those roles located? How are they funded? Or how do people access the program? Does the program track caregivers? And is that also a potential source of data for programmatic planning across the state? So a little bit more about the program in detail, because I'm sure other states have something similar to this, maybe set up in a different way, but there might be some learnings from Utah.
I'll start with our contracts. I mentioned that we have 2 contracts that go out for caregiver consultations. One of these is housed at the University of Utah in the Department of Neurology. They have a cognitive care clinic there. And then the other one is with the Alzheimer's Association, the Utah chapter. And we do get a lot of data from the caregivers that they see. These care consultations really follow the caregiver throughout their journey. So it depends when they start, but they do go through how to prepare, what type of paperwork needs to happen, guardianship, power of attorney, any end of life decisions. And our University of Utah folks also provide phone calls so that if the caregiver is going through a challenge, let's say they've made the decision to move their loved one into long-term care, they can actually call, it's a social worker at the University of Utah. They can call the social worker and kind of work through those feelings and get advice and things like that. And they're also really connected to the area agency on aging for that caregiver, so they can connect them with people like the ombudsman who can help them select a community for their loved one that works for their needs. Or we have a geriatric psychiatry clinic. Maybe someone needs help there. And so we're really referring to each other a lot. And both of our contracts are focused and required in the contract to refer to any services in Utah. And we really go through and list those out. So, for example, the Alzheimer's Association, while they have a fantastic, huge breadth of resources, they're also referring to our AAAs and some of our more local resources that may not necessarily be listed on an Alzheimer's Association website. Kate, do you have anything you want to add to that?
Sure. And as far as care consultations that the area agencies on aging provide, of course, just getting connected with that local AAA, the case managers can then sit down with that caregiver and have that care consultation or provide that. Christy and I also do care consultations. So there's lots of avenues for folks to be able to access that service. While care consultations are helpful at any point during the caregiving journey, I personally think they're most helpful as early as possible. So if we can get in front of a caregiver as their caregiver journey is starting, or as close to the beginning as possible, that really helps us to be able to open all of those doors of resources and support to them and guide them accordingly, and really kind of help them to get off on the right path. Versus what we can see if they don't have that connection, they don't have support, is they're really struggling, trying to keep their head above water, and find themselves, immersed, being immersed a number of times. And so, really, that's what we would like to see, is care consultations being provided as early as possible, so that our family caregivers can get the most benefit. And that then just means that folks need to be referred to that service as early as possible. So we do a lot of work trying to raise awareness among other professionals that care consultations are available, so that they can refer family caregivers, or healthcare providers, so that they realize once a diagnosis, let's say, of dementia is being made, or a diagnosis of cancer, or whatever it might be, taking it kind of to the broader caregiving discussion, that they think this individual is going to have somebody, or is going to need somebody to support them along their care journey, and that individual is going to need support as well. And so let's get that individual connected to the resources available. So we're trying to also focus on having others be aware, other professionals, other referral sources being aware of the vital resource that a care consultation, is, and to get them connected as early as possible so they can access that.
Thank you. Thank you very much. A question maybe related to this is about promotion of resources, and specifically is someone has asked to hear more about your public awareness campaign. What specifically are you doing to increase public awareness? What approaches from the public health perspective have really been successful? And
okay, so our public awareness campaign, the contract right now is with iHeartMedia. So our campaign technically is through radio, social media. They've taken over some of their partner websites. We do targeted emails, things like that. However, we also create some social media things in-house and share those with partners to be co-branded. And we've also created, you can see it on our website, but there is, and I'll put the link in a second. I just need to find the exact link and I'll post it. But we've created a card that says, the person I'm with has dementia. And I used to have one really close by, but I don't right now. the person I'm with has dementia. Thank you for your patience. Thank you for your patience. Speak kindly. And then on the back, it talks about that dementia can impact your memory, behaviors, thoughts, and other things. And then it gives an option for people to learn more by either scanning a QR code or going to our website. And it also provides a 1-800 number that's actually answered in-house by our aging and adult services staff. And so we are constantly trying to find ways to enhance this. Just this last legislative session, the Alzheimer's Association was awarded funds for a rural and tribal public awareness campaign that hasn't started yet. Like I said, it just happened. Our legislative session ended like a month ago. And so we haven't started that yet, but it is going to be primarily actually hard copy mailers. As I mentioned, about 40% of our folks in rural and frontier areas don't have access to the internet. So we're really focusing on how to get this information out to these folks that may not see it online. And so we have a lot of our data from our metrics there. We are truly covering statewide with iHeart, which is why it's working out so well. And really, this is input from everyone. Those little cards that I mentioned were created because there was some once upon a time that were created by the Alzheimer's Association that were no longer in print. And two, our first responders from one of our counties reached out and said, hey, we have some folks that call in repeatedly and they need help and they need resources. Is there just something easy we can hand them to link them to you? And so we actually have some of our first responders that are carrying these cards and hand them out to caregivers. But we also have caregivers carrying these cards, handing them out to the waitress at a restaurant or handing it out just kind of secretly to someone at the grocery store. So if they feel like they'll embarrass their loved one with dementia by saying, hey, my person has dementia, just FYI, if they do something strange, don't be alarmed. Now they can just pass this card. And there's been a lot more understanding. We are going through them like hotcakes. So we're really proud of that.
And I see there's a question in the chat about have we asked how individuals living with dementia feel about these cards? So I think like with anything, some people will like, what we've got to offer and some people won't. Everybody has their opinion, of course. So as Christy mentioned, I used to be at the Alzheimer's Association where for the Utah chapter, I led the programs and services across the state. And I used to host early stage support group meetings and had many, many conversations with my clients that would attend those meetings. And for the most part, they were just thankful that there were these opportunities that their loved one, when that person with dementia progresses into dementia, that person that's supporting them has an opportunity to be able to hand something to another individual to say, my loved one might need a little more patience today, or understanding versus having to verbally say that when the person the individual with dementia at that point that might not register or might not be a good time for them the caregiver to be able to say that, if that makes sense. So individuals with dementia that I've worked with, I mean, again, everybody's a little different, but they just want to know that in the future there's support for them and that the person that's mainly supporting them is going to get help. And so they've been very positive in responding to these cards. So that's what we've seen here in Utah. And what I really love about the card is not only is it kind of gives that opportunity for the person you hand it to reframe how they might be speaking to or working with the caregiver and the person with dementia. But also on that back, of course, there's an opportunity for them to go somewhere and learn more, which is what we're all after as well, as raising awareness. So that's another thing that I love about the card.
Thank you. Thank you so much. And Christy, I see that you put a link for those cards in the chat. Thank you so much. And if there's any other materials you've developed as part of your awareness campaign, please do provide links directly. I know folks can go and check your website, but it's always good to have them handy. Please feel free, because oftentimes there are materials that can be reutilized, slightly adapted.
Absolutely.
Maya?
Absolutely. And
Yeah.
I saw somebody ask about how many caregivers are represented in our pie chart. Can we roll back to slide 13 and show that pie chart? Sorry, I don't get dizzy, everybody. I saw this and I was kind of excited because where I have caregiver listed up there in the top left, that is all family informal caregivers. We do that, it does not list any professional caregivers. That is all family informal caregivers.
Yeah, we do know that there are professionals who are also caregivers. We know 60% of family caregivers work. Um, but as Christy said, that caregiver space there is, these are unpaid family caregivers. So when we do have, and we have folks within our coordinating council who are representing a specific area, like let's say Department of Health and Human Services or the University of Utah, and they also are caregivers. As I mentioned, 60% of caregivers are working. So when we have family caregivers who are working representing one of those other entities, we just have them linked under their professional connection to the coordinating council. So
Thank you so much. There's another question in the Q&A about someone who wants more information on the caregiver kits that were mentioned as being used in the public libraries. And they're wondering how the data is collected on the number of caregivers and people living with dementia that are accessing these kits.
sure. So every area agency on aging, well, I should say not every area agency on aging utilizes caregiver kits. But for those that do, each kit can look a little different. So mainly there will be a number of items within that kit that the family caregivers can pick up at a time, and they can, let's say they check it out for a month. Take their time really kind of exploring different items in the kit and then return it when they're ready. They can either pick that up from their local area agency on aging, or some AAAs will have partnerships with their local libraries or library system. And so they can promote within that library that they have maybe a caregiver section of the library where they can they can check out books or videos or caregiver kits to really help them along their journey. For the most part, I believe when data is collected surrounding these kits, it's the number of people that are checking out the kits, and whether they felt the kit was helpful or not. Again, what you can find in those kits is maybe there's a couple books for the family caregiver that they can read themselves to learn more. There might be an activity or a couple activities that the caregiver can do with the care receiver, some activities the care receiver can do on their own to give that caregiver, of course, an opportunity to kind of step away and take a break. So there's a mix of what you can find in there. But at this point, I think as far as data collection, it's really surrounding what kits are popular, what's being checked out, and if they've been helpful or not, or if they enjoyed engaging in that kit.
And some of our more rural areas actually don't have the kits for checkout. They'll create the kit specific to their client and then give the caregiver and the client that kit. For example, someone really liked gardening, and now with their dementia and maybe some physical limitations, the AAA actually put together a kit that had pots so you could sit at a table and plant the flowers, and it had the dirt and the pots and the shovels and everything that you need to be able to do that. So it's very different. I know our biggest library is Salt Lake County, of course, and they have kits, and I am looking vigorously for a link to that. Of course, I can find it easily when I'm not presenting to you all, but now I'm searching for it, so I'll keep doing that. But
Great. Yeah,
we're excited
please,
about those.
yeah, please, if you find it, do drop it in the chat and we will call everybody's attention, because there is a lot that's being shared in the chat. While you do that, maybe a related question, that information that might show up in the kit, but Kate, how do you incorporate end-of-life planning into your program is another question.
Sure. So I think with the ADRD program, we would like to build out a portion of the website to really highlight, what folks need to consider as dementia progresses. So that's one thing. But with the ADRD program, as well as the National Family Caregiver Support Program, end of life planning can be something that is discussed either in a care consultation, one-on-one, really getting into that specific caregiver or person with dementia's needs and wishes, or could be addressed via an education program. For example, we might partner with one of the area agencies on aging to offer a specific education program that kind of gets into end of life planning. We might partner with a local elder law attorney that will come and do presentations and provide some information. We might partner with organizations like the University of Utah, AAA, the Alzheimer's Association, the VA, and provide, in which we do, and provide conferences that caregivers can come to. And one of the topics we talk about will be end of life planning and things to consider for planning for the future. So we have an array of kind of how we address that.
Right. Thank you, Kate. The planning in dementia care, is so important, of course, at end of life, but also throughout the entire course of the dementia. And it's never too early to start planning. And on this topic, I wanted to share a resource guide that my colleague Maya helped develop last year of our center. It's actually intended primarily for use by people living with dementia and caregivers, but also public health departments and agencies can disseminate it as well. And it has a lot of links and resources and some recommendations or for what to look for at each stage of dementia and where to turn maybe for assistance with care planning. So that is also in the chat there. Christy, if you do find any other those toolkits, please feel free to drop them in there as well.
Yeah, thanks, Alma, for sharing that resource, that guide. We on our website, the dementia.utah.gov, we link to a number of different guides as well. And so we will, if we don't already have that on there, I have to open up to see which one it is. But we'll add that, of course, to our website. But yeah, that's just another way, just being able to connect folks to those resources, maybe the AARP Prepare to Care guides, or one of our area agencies on aging in Utah actually created a caregiving guide as well. And so all of those are linked to our website as well.
Great, thank you. We can never have too many resources, right?
Exactly. You never know which one will speak to each person. So having those options, I think, is helpful.
Yeah. Another question that I wanted to ask you about was when you were on the slide where you were talking about the evidence-based programs for caregivers that are offered throughout the state. And I was wondering if you could share a little bit about, we talked about how Utah has been really very creative in adapting interventions and programs for caregivers living in geographically dispersed areas. And also, but can you speak a little bit about the cultural adaptation that has been made, if there has been any, to any of those programs? What were those changes? And kind of what the role of the public health department was in that process? If
Sure.
anything comes to mind. Yeah.
Yeah, Christy, do you want to speak to, I believe we've translated, or we've worked on translating a couple different programs. Well, I'll just start with Salt Lake County Aging, again, another one of our larger area agencies on aging, has really looked at the needs in their community, and that's the most diverse county in the state. We do have a lot of refugees in the area, as an example. And so they have, for their caregiving guides and education programs that they offer, they've translated to a number of different languages, Spanish, Russian, for example. So And of course, we share that across the state as we can. I know Christy's been in contact about translating, I think it's dementia dialogues or dealing with dementia into other languages as well. So I'll let her speak to that.
Yeah, so Kate mentioned the Salt Lake County Aging. I put a link to that in the chat. And the way that they decide on what to translate it to is Salt Lake County has a very large refugee community, and so they actually hold focus groups with these communities, and they make them both culturally and linguistically appropriate for those communities. So the link is there, and you can see all of the different languages and cultures that it's been translated into. And some of our ADRD funding has helped with that. However, Salt Lake County has done all of the work. I can't take any credit for that. And then we've also worked with Dementia Dialogues, which is out of the University of South Carolina. And we've translated that into Spanish a number of times. They just completed an update and they are going to be doing that translation on their own this round. However, the purpose for us translating it is because we had people asking for it. I mentioned when I was showing what our state looked like, we are predominantly non-Hispanic white. And so really we translate and make things more culturally appropriate based on need and what communities we're able to gain access to. And so we haven't done a lot of that within the dementia program itself, specifically because we have Salt Lake County who's doing it for theirs. And then as we continue forward, I do have a contact within Navajo Nations, and they are wanting to do some translation of some of our programs to make them more culturally and linguistically appropriate for them, which is very exciting. But again, we have to work through that Utah Indian Health Advisory Board. So it's kind of a slow process and we're getting there.
Yeah, and prior to COVID and even through COVID, because we know that as I mentioned, COVID really hit our tribal communities hard. We were sharing with the Utah Indian Advisory Board resources from the International Association for Indigenous Aging. So the offerings that IA Squared has have been very helpful, and just kind of making sure that they have access to those and that they're aware of those resources until we could kind of pull back around together now that COVID has kind of settled, and have those further discussions with the tribes.
Thank you. Thank you so much for this great session today. We are just about at time. And while we still have a few people on some of our audience, actually majority of our audience online, I wanted to just invite everybody to please give us your feedback and what you thought about today's presentation. Of course, also feel free to reach out to our presenters with any follow-up questions. Maya, if you don't mind just maybe going back to the slide where their contact information is. While you do that, I am going to plug in a link to our online survey. It takes a couple of minutes. Just tell us what you thought. And if you have any ideas of content improvement we can do to future webinars, we really take it to heart and we do implement it. Thank you again. It's 12:30 here Central Time. Christy and Kate for taking the time. This has really been wonderful. Very, very formative and informative for me, for all of our public health colleagues through the US. Any final thoughts? Anything you would like to share?
No, we're just thrilled to be here. Please reach out and contact us if you have any questions, you want to collaborate, you want any of our stuff. Here's how you can find us. And thank you to the center for having us. We're really excited that you thought of us.
Yes,
the honor is ours.
Thank you so much.
Thank you.
You are welcome. Today's recording slides and also the content in the chat will be emailed to everybody. So you all will have access to those resources after the session. Thank you for being here today. Have a wonderful rest of your week.